Welcome to another deep dive. Today we're going to be tackling a debate that's shaking things up in critical care medicine. We're talking about lung injury in patients on ventilators. Now, I know that might sound a bit technical, but trust me, this is about way more than just medical jargon.
It really gets to the heart of how we understand cause and effect in medicine, and that has huge implications for how doctors approach treatment.
Exactly. Our deep dive is based on a fascinating paper from the Journal of Mechanical Ventilation. It's titled Ventilator Associated or Induced Lung Injury. Does the name matter? The paper features a point-counterpoint discussion between two experts who are, shall we say, passionately debating whether is VALI, ventilator-induced lung injury, or VALI, ventilator-associated lung injury.
And that seemingly small difference in wording actually reveals a lot about how we view the relationship between mechanical ventilation and lung injury.
Okay, so before we get into the nitty-gritty of the debate, let's make sure we're all on the same page. We know that mechanical ventilation is a lifesaver for patients who can't breathe on their own right.
Absolutely. It's essentially a machine that breathes for the patient, delivering oxygen to the lungs when they can't do it themselves.
But as with many medical interventions, there's a risk of complications. And in this case, one of the biggest concerns is lung injury. So the question becomes, is this injury a direct result of the ventilator itself, meaning the machine caused the injury, or is the ventilator just associated with the injury, meaning it might be one factor among many others at play?
And that's the crux of the Villi versus Vieli debate.
Let's start with author one, who makes a compelling case for Vieli, the associated side of the argument. Their perspective leans heavily on statistics and the philosophy of science, in particular the concept of inductive reasoning.
Which essentially means drawing conclusions based on observations. We see a pattern and we infer a general rule. But author one cautions that just because two things happen together doesn't automatically mean one caused the other.
Author one's point reminds us that while medical research often reveals correlations, proving a direct causal link, like definitively saying the ventilator caused the injury, requires a much more rigorous approach. Sometimes it's hard to isolate the machine as the sole culprit because there's so many other factors to consider.
Exactly. Think about a patient's underlying illness, their overall health, other treatments they're receiving. It's a complex web of factors that can contribute to lung injury.
And just to add a little historical context, author one points out that the term ventilator-associated lung injury has been around for over 2 decades. It was even used back in 1999 by the International Consensus Conference on Critical Care Medicine, so there's some serious precedent for the term.
Which suggests that this isn't just some newfangled debate. There's a lot of nuance here that's worth unpacking.
So have we convinced you yet that it's all about association?
It's certainly a compelling argument.
Yeah.
But now let's dive into author two's counterpoint. They're firmly on Team Michaud, advocating for the term induced.
So they're pushing back on this whole correlation versus causation idea.
Exactly.
Yeah.
Author 2 argues that induced is a more accurate term because it highlights the direct role of the ventilator in causing harm. And they go beyond just stating this. They delve into the specific mechanisms by which the ventilator can damage the lungs.
I'm all ears. Break it down for us. How can a machine designed to help breathing end up hurting the lungs?
Well, one way is through something called barotrauma. Imagine you're inflating a balloon. If you keep pushing more and more air in, eventually it bursts. The same principle applies to the lungs. Excessive pressure from the ventilator can actually rupture those delicate air sacs, leading to some pretty serious complications.
Wow, that's a powerful image. I can see why clinicians are so cautious about those pressure settings.
Absolutely. But it's not just about pressure. There's also something called volutrauma, which is damage caused by too much volume being forced into the lungs. Think of it like stretching a rubber band too far.
Okay, so pressure and volume are both key factors. What else should we be aware of?
Author 2 also points to atelectrauma. And this one's a bit more complex. But think of it like repeatedly crumpling and uncrumpling a piece of paper. Eventually it starts to tear right. The same thing can happen in the lungs if the air sacs are constantly being opened and closed by the ventilator.
So it sounds like it's not just the machine itself, but how it's used that can cause problems.
Precisely. And author 2 makes a pretty bold statement. They suggest that VILI could also be termed clinician-induced lung injury, emphasizing the crucial role clinicians play in setting up and managing the ventilator properly.
So they're putting the onus on the clinicians. That's a big responsibility.
It is. And it highlights a really crucial point in this whole debate, the human element. Even the most advanced technology is only as good as the person operating it. And of course, the paper also acknowledges that the picture is even more complicated than that. There's a whole host of other factors, from patient ventilator dysynchrony to ventilator-induced diaphragmatic dysfunction.
It sounds like there's a lot to consider here. So where does that leave us? Is it Villay or Ivai? It seems like both sides have valid points.
You're absolutely right. This isn't a simple black and white issue. The reality in critical care is incredibly complex. There are so many variables at play. It's incredibly difficult to tease apart cause and effect in a critically ill patient.
So if pinning down the exact cause is so tricky, how do clinicians approach this in practice?
Well, the paper does mention how the CDC has tried to clarify things by introducing a broader category called ventilator-associated events, or VAEs. These are essentially observable changes in a patient's condition that might be linked to the ventilator, but don't necessarily prove direct causation.
So it's more about identifying potential problems and addressing them, regardless of what we label them.
Exactly, and that's a very practical approach.
Right.
But even with the CDC's broader category, the Villi versus Veli debate still matters.
Why is that? If we're focusing on those observable events, why does this specific terminology still hold so much weight?
Because the words we use shape how we think about problems. They influence how we direct research, and ultimately, how patients are treated. So even if the CDC has a broader category, the nuances of VLI versus VLI are worth considering.
That makes a lot of sense. It's not just about semantics, it's about framing the problem accurately and then figuring out the best way to approach it.
And that brings us back to author two's point about the potential for automated intelligent ventilators.
Right. They suggest that these smart machines could take some of the guesswork out of setting and managing ventilation, potentially leading to better patient outcomes. It's fascinating to consider how technology could play a role in reducing lung injury. But I imagine there are a lot of questions about how to implement that safely and effectively.
Definitely. It's not just about having smarter machines. It's about integrating them into clinical practice in a way that enhances patient care and safety.
This has been such a thought-provoking deep dive. It really highlights the importance of staying curious and questioning those seemingly simple assumptions.
It really does. And it reminds us that even a simple difference in terminology can reveal a whole world of complexity in medical science.
But before we wrap up, let's bring it back to our listener. Why should you care about this Valine versus Villi debate, even if you're not a medical professional?
I think one of the biggest takeaways here is the power of language. The words we use shape how we understand problems, not just in medicine, but in any field.
So being more mindful of those nuances in language can help us be more critical thinkers.
Absolutely. The next time you hear about a medical link or cause, think about what's really being said. Is it a proven causal relationship or just an association? That's a question worth asking, even when you're just reading a news headline or listening to a scientific report.
That's a great point. It reminds us to always dig a little deeper and not take things at face value. So to wrap things up, we explored the complex debate surrounding lung injury in patients receiving mechanical ventilation. Delving into the nuances of Villi versus Villi, we learned that it's not just about semantics, but about understanding the very real challenges of proving cause and effect in medicine.
And we saw how this seemingly simple question about terminology has sparked important conversations about the role of clinicians, the potential of new technologies, and the ever-evolving nature of medical science.
It's a reminder that even in the face of complex medical challenges, there's always hope for progress. And as our expert pointed out, being mindful of the language we use can help us navigate these complexities and become more informed and engaged participants in these crucial conversations. Thanks for joining us for this deep dive.